Well, so what I did is I sat back there about 4 times and changed things around a little bit. You guys got really superb lectures. Alekos gave a great lecture about all of the alignment stuff, which I think is really important. Steve gave a really good talk about a number of different factors as far as sagittal alignment. Vincent gave just a great talk about the history and leading into what our current things. So I modified this around a little bit to at least give you a little bit of new information. Let me see here. There we go. These are my conflicts that I have. And what I want to go into sort of impart, the single biggest piece, is I don't think that there's any single new widget or device that's going to revolutionize spine surgery in the next 5 or 10 years. And I think that it's things about learning better techniques. I think it's having more information, as Jens just asked about, Baruz about AI to predict what things are going to particularly move in a particular direction. And I think that some of the newer technologies, like robotics, I think will help to go more in the planning stages. I think many of us, particularly if you've trained with Jens, know how to go and to put in a pedicle screw. I think everybody in this room knows how to do that in most cases. And I don't think it's knowing that better is going to help us as other different factors. So what's happening is I do want to say that, I think most of the equipment that we have available to us allows us to correct most deformities. This is a patient who had 13 different operations, implants in, implants out. They couldn't put pedicle screws anymore, so then they used hooks, and that failed, and it was eventually sent to me, and this is what I ended up doing, using, basically the standard techniques that we had, and I just did 2 different levels, as Vincent showed earlier, 3-column osteotomies to do that. Now, one of the things which I think as far as information is concerned is the ability for us to collaborate with each other. And, and when I was first starting, Jens got me involved with the AO and where I met Vincent and others. And one of the things which I think has been really helpful is something called the ISSG, the International Spine Study Group. And you've seen a number of the different papers where different information from them have come together. And this brings together, orthopedic and neurosurgical spine surgeons. And by going and having big groups of data and having the ability to analyze it, including different things like AI, I think it goes and begins to teach us certain lessons that are being brought forward. And this just shows the productivity publications from the ISSG and shows this is sort of a new paradigm. It used to be a big center like Minnesota or a big center like WashU with Larry and Keith Bridwell used to do it. But as you go and you're able to do this, you're able to have the impact to be able to go and to bring really true knowledge that helps all of us move forward. And there's going to be some real importance. And this is a branch of the ISSG. This is our MIS branch, and you can see all sorts of the who's who in orthopedics and neurosurgery doing MIS surgery. And answering some of the questions is who benefits the most from MIS is something that is important to know, and at least in a semi-objective manner. Now, as I start the portion of my talk, I just wanted to show you, I in general should know better, but despite me thinking that I know better, occasionally I'll end up with a patient like this, and this was a 68-year-old who had severe MS with difficulty standing upright. And this is her best ability to stand, but very frequently within 5 or 10 or 15 minutes, she would go into greater coronal and sagittal malalignment. And she had severe lower back pain. Someone attempted to do a L4-5 T-lift, which didn't help that much. And this just shows some of the images on her. And I said to myself, okay, what things should we do? How should we optimize? And this is looking at her bone density, which looked to be reasonably good. And I said, well, what should I do for this patient? And again, this is a person who has a neuromuscular condition that doesn't always follow the same rules that we follow for adult deformity. So one of my things is that, that she because of her severe MS, she had to catheterize herself, okay? And one of my considerations was, do I want to go to the upper thoracic spine, and could she actually see to catheterize herself if I put the screws in? So I thought about this, and I sort of debated about myself. Should I go to the upper thoracic spine? Should I go to the lower thoracic spine, or should I say no? And so this is what I did. And I thought, oh yeah, well, I got her lumbar spine fixed. You can see I used some new technology, or kickstand rod or whatnot. And her thoracolumbar spine is pretty well aligned, both in AP and lateral. And so I was a little bit distraught that this is her 1 year after, and her thoracic kyphosis is increasing, and her malalignment, which was flexible on her preoperative films, continues to worsen, and she's tilting more and more and more and more. Here we are 2 years after. And I said, geez, I just clearly did not pick the right levels on her. And you can see she's got about 90-degree thoracic kyphosis. Now, part of this is, again, it's sort of a neuromuscular condition. And I said, okay, what should I do for this now? And these are the options to do it. And again, once you grab the tiger by the tail, there's no letting go. I mean, this is now my patient, all right, so I got to do something. She's driving me nuts. So basically, I did this. I said, well, maybe this is what I should have done in the first place. If I had done this, then I would have saved myself all sorts of trouble. And I looked at her, and this is these are relatively early. You can see that there's still some lines on. This is her standing up after her surgery, and she initially seemed to do well. But 9 months afterwards, you can see the top of the EOS image right up there, how her neck is now canting forward. And basically, you can see that she probably had a bit of a screw pull out and other factors to do it. So basically, I said, okay, all right, here I am. I've grabbed this tiger. This tiger's now fused to C2. Just to the point, you can see she had an abnormal vertebral artery on the one side. So you can see a par screw and a laminar screw in that area. And again, she did okay. But about 6 months after the surgery, she tripped and she fell, and you can see this atypical hangman's fracture that she developed from the fall. Now, probably if I had done 2 par screws, if I was able to do it, she probably fractured her odontoid. But with this, she had an atypical hangman's fracture, and I said, okay, now what do I do? And, I think a number of people would have fused her to the occiput, but I really, really hate fusing people to the occiput. So I ended up doing this and doing a anterior discectomy infusion. And here she is about 6 months after the surgery, still able to move her head around. But the fact is, should I have done this? And how do you grab this tiger by the tail? And, and what can we do to try to prevent this thing, which was very painful for me, and, I'm sure very painful for the patient. So one of the things, sort of the lay literature, when, and you hear this all the time, and Jens touched on it indirectly, is why are we doing so much adult deformity surgery? Is it doing it because we make so much money doing it, or is there another reason? Now, I'll tell you, for all, some of you guys in private practice, you do a heck of a lot better doing 3 T lifts in a day than you do, a T2 to the pelvis thing on some Medicare or Medicaid patient. So the fact is, I really think that there's very few of us who do adult deformity do it purely to become rich. There may be somebody out there who's figured out the secret code. And what's happening is all this stuff, back surgery should be avoided. Back surgery should be avoided. If you look at there's an article out from the New York Times said the 3 things you should never have done. Number 2 of the 3 things in medicine is to have your back operated on. But one of the problems is that there's a failure for a lot of people to understand the impact of adult deformity on the individual patient. And this was a study done through the ISSG looking at the health impact using the SF-36. And this is sort of the raw data, but this is the important data right here. And so people say, well, there's people, I know one of my friends, whose wife has had, untreated idiopathic scoliosis, and she seems to be doing okay. She outplays tennis, everything else. And the fact is if you are a middle-aged person with no sagittal or coronal alignment, with good lumbar lordosis, and you just have an isolated thoracic curve, you function just the same as an age-matched control. But if you look at the person in the middle, 63 years old, has a scoliosis, has some sagittal malalignment, and that function is functionally equivalent to having an above-knee amputation. That's how much they're limited. And then you look at the far extreme, and the 78-year-old woman who's really severely deformed, she has got a functional equivalent of being blind, a bilateral above-knee amputation with heart and lung failure. And what happens is, because these people are so devastated by their condition, they keep on coming back and coming back and coming back. And if I don't treat them, or Jens doesn't treat them, they're looking for somebody to give them some hope or relief. And I had a patient who came in this age, but who had multiple medical comorbidities. And I said, I don't think I should operate on you, and I don't think anybody should operate on you. And we put her into hospice, and they immediately, when they went and did all their testing and whatnot, they said, this is the single most sickest, most debilitated person we have ever seen. And they readily accepted her into hospice. But what happened is that this deformity over the course of 20 years ruined this person's life. She couldn't walk, she couldn't do anything, and that's why we are done. So a little bit of this is, what's the disconnect, okay? How's the perception that we really shouldn't be doing this surgery versus the practical reality that people who are actually suffering with this are really have a hard time. Now, fortunately, Keith Bridwell, about 15 years ago, started the adult symptomatic lumbar scoliosis trial. It's an NIH-funded trial. I was one of the participants, and I was on their executive committee, where we basically tried to randomize people into operative and non-operative care. And after the initial 5 years, the NIH thought that too many of our non-operative patients crossed over. But if you have somebody with severe deformity, it's hard to keep them in a non-operative status. But one of the things that's done, and this is the 5-year data, and the 8-year data is in the process of being published in JAMA. But what's happening is, if you can see there that the upper graph is the operative treatment, and the lower graph is the non-operative treatment. And the fact is, the non-operative people never get better, and as you look out to 8 years, they begin to even further deteriorate. But if we do a reasonable job with surgery, and don't have horrific complications, this is exceptionally durable. And actually, the fact is that the 8-year data is better than the 5-year data for the operative patients. They're doing even better. So we have something that really works on people, that's really durable, but also has an extraordinarily high complication rate. So if you get them through this, and again, you're out at 5 or 8 years, they're doing well. But in the short term, there can be some real difficulties. And this is some information of the impact of having a neurological deficit. This is from the SCOLI-RISK trial. This is Larry Lenke and Michael Failings and I and some other people looked at it. And if you end up having somebody who's a neurologic deficit, there's some real impact in the long term as far as what goes on. So what happens is, again, if you look at so much in the literature, they say, oh my goodness, there's too much of this surgery being done. And this is from Rick Deo from this area here, who goes and talks about how the complex fusion surgery is being overdone, and there's too much of it being done, et cetera. And what's happening is, in part, this is driven by that these surgeries do have really sobering levels of complications. This is some work that was done by the Adult Spinal Deformity Group, and what it showed was complications are high, can be up to 80%, and it's higher in people who are older, who are heavier, who have other pre-existing comorbidities. Those are people who have had previous fusion surgeries, and those people who undergo 3-column osteotomies are all people that have complications. If you have to do something like a 3-column osteotomy, the complication rates are even higher, and they're suddenly in the 70, 80, 90% group of people who have complications, including fairly serious ones with this. I'd mentioned this previously. This is from the SCOLI-RIS trial, showing that probably somewhere around a third of our major adult deformity surgeries develop some form of neurologic complication if you check on them. And again, these have negative impacts. If you get a neurological deficit, you don't do as well from either back pain or leg pain standards. But again, how do we relegate, looking at this, the NIH data, so boy, these people have got a durable, excellent result with some of the other different things. And again, I think so much of it is related to our complications. So this sort of circles back to this patient here. This is a patient who came to me, 82 years old, generally good health, walked 2 miles daily 2 years ago, but now can't even make it out to her mailbox. She has severe back and leg pain. She got an ODI of 61, and her imaging looks like this, okay? And the fact is that I kept on saying no, 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 and every 3 months she's back. You know, she's calling, 6 weeks calling up my office. Oh, you got to do something. You got to, we tried facet joint injections, this, that, and the other thing, and so finally, again, her daughters are there saying, look, you got to do something for her. So the question is, should this patient be a candidate for surgery? Are there strategies that we can do to reduce risks of surgery, and should there be a complication threshold where we just say, absolutely, totally no, we're just not going to do something? So again, this is the quandary just wrapped up in a nutshell. Is that basically as you get older, higher risk of complications, and you can see in the 65 to 85 group, you're having almost a 75% incidence of complications. But if you look at the bottom graph, if you're operated on 20, if you're operated at 40, if you're operated at 60, if you're operated at 80, you're going to come up with the same result. And the delta, the people who do the best and perceive that they improve the most, are the oldest and most complicated. And again, how do we reconcile all this to go and decide what to do as far as the right thing? So basically, I did this operation, 5 hours, 1,300 cc's blood loss. Post-operatively, she developed delirium, ileus, AFib, urinary retention, 28-day rehab stay after being discharged, and moved into assisted living because her daughters felt that she couldn't take care of herself by herself. And is this from a societal and from a health economic perspective, was it a reasonable thing for me to do? And I still don't have an answer. But her ODI is 22, and she says, I feel so much better than I did before I had my surgery. So is this a good or bad outcome? I don't know. Were these expected or unexpected complications, the list I gave you, and are these things preventable or unpreventable? So the biggest thing to understand is that so much of what we're doing is based upon frailty. And what's happening is if we can find some ways to reduce these serious complications, and this is from another AO study, the PED study led by Steve Lewis, that we can get really good results. So what's frailty? And this is something that has really been understood to a much better degree by some of our other colleagues in medicine. But basically, it is the ability to go and bounce back from some type of insult. And what happens is your body has less and less ability to bounce back. The chance of you recovering and doing well from surgery becomes less and less. And this was a study looking at postoperative mortality in general surgery patients. And what they found was that by doing a complex frailty score, looking at other disease conditions, looking at nutritional status, looking at functional status, they could exceptionally accurately depict who's going to do well, who's not going to do well, who's going to end up in a nursing home, and who's going to die based upon these frailty measures. And this is one of the frailty measures that they used in the study to determine frailty. So one of the things is that, when we're operating on somebody, both these people are 79 years old, and which one do you think is going to do better with the operation we're going to do? And the fact is it possible for us to convert the lady on the left into the lady on the right, making our surgery much more effective? So through the ISSG, we developed a frailty tool, and this is going to get to the real important part of this. And we looked at a lot of different measures, and one of the problems with the ISSG is we collect about 180 data points at each time we see them for every patient we see, which is an extraordinarily involved and costly process, but it gives us good information. And so what we ended up doing was doing an initial study comparing people that we called normal compared to people that were frail, compared to people that were severely frail. And if you look at the paper, it's just, again, what you would expect. There's different factors into it. And one of the things which was so important was the people that did absolutely the best with adult deformity patients were frail patients. The frail patients, because they were sicker and you improved their global health status, they did better. And what happens is if you do a good operation in an adult deformity patient, you can help impact their type 2 diabetes because they're able to be more active and lose weight. You can improve their sarcopenia through other different things. There's other disease states that are improved by fixing their deformity. But what this study showed was that the people that you could not get a good result, that the complication rates were so extraordinary that you never caught up for those patients that were severely frail, okay? They just never did well. So the fact is that, sort of the holy grail of what we're doing is deciding to do it about making people convert from being severely frail to merely frail, where we know that they're going to do well. And those people that we cannot improve their status are not wise to operate on. So this is just say, we continue to do it. And so what we do is we have a fairly complex preoperative evaluation, and this is done through something we call the PASS and the POSH clinics at Duke, where we gather all of this information and we see which modifiable risk factors are able to be modified, and used an AI-based calculator to be able to show people, hey, look, if you do this, this is going to be the eventual impact on your outcome. So some of the things we're absolutely strict about now, for example, is hemoglobin H1C. It's been shown it's a very, very highly associated with postoperative wound infection and other problems. And essentially, I will not operate on anybody unless we get their hemoglobin H1C below 6.7. We will not, and now with the new GLP drugs and whatnot, that's a bit easier to do, but that's something that we're absolutely done, and this is just several studies showing it. The second thing is many of these deformity patients, because they're in pain and whatnot, are malnourished, and this is some work from Duke, and I think Sergio was involved in this. And what it showed is if you have an albumin less than 3.5 grams per deciliter, your risk of complications, again, just extraordinarily increases. And to check and to get people nutritionally optimized to do it. Now, one of the things is you have somebody who'll come in who's got a BMI of 47, and you say, well, this person can't be malnourished. Look how fat they are. But this right here. This is a guy who was on YouTube, and basically he spent 6 months drinking holy water, his only form of nutrition for 6 months, that he drank the thing where he got a bag of Doritos and a quart of Mountain Dew and ground that up and drank this holy water for all 3 meals. And so what happened at the end of it, he went from like 250 pounds to 422 pounds, and it completely ruined him, including he had problems related to hypovitamintosis and other things that happen. And believe me, at least in the backwoods of North Carolina or Virginia or West Virginia, you got a lot of people who probably are subsisting on holy water. So you want to go, as you heard earlier, about cardiac evaluation. You want to do for MRSA colonization at Duke. We now already pre-treat. We treat everybody like they've got MRSA. So they do preoperative benzoin nasal swabs. We do a lot of things that have been shown, and a lot of things to reduce different complications for there. So it was touched upon earlier. One of the things which we are really, really strict now about is prehabilitation. And there was an initial study, this one right here, where they looked at people undergoing major vascular surgery, aortic aneurysm repair, whatnot. And physiologically, that's probably the closest impact surgery to what major spine deformity is. And what they found was by having a 8-week prehabilitation program prior to the surgery, they reduced the complication rate in half and the mortality rate in half. And so we vigorously prehabilitate our patients. Steve Glassman touched upon bone density, and so it's got an effect on pedicle screw fixation. It's got an effect on adjacent segment disease. We start off as a minimum of checking the vitamin D levels on all of our patients because that also impacts bone healing. But everybody, every woman over 45, every male over 65 gets a DEXA scan, and we really also look at the Hounsfield units at the areas of stress to make sure that that's all correct. And if it's not correct, then we talk about using some type of supplementation. This is teriparatide as an option, and the use of teriparatide and some of these other agents really can do a dramatic difference as far as improving bone quality. And there's several studies where we're looking at now through the ISSG and others showing that it does improving bone quality does reduce the risks of proximal junctional failure and rod fracture to do it. We want to reduce our blood loss during surgery, which is important. We heard that Steve had showed you about the impact of hypotension. So one of the things we want to reduce blood loss. We want to look for different things. A lot of people throughout the world take an awful lot of nutritional supplements, and some of those can increase bleeding. We want to be able to go and again, particularly in North Carolina, everybody has goodies powder. You say the person bled a lot during surgery. I said, did you take? All I took was that goodies powder, and that can cause impact. And one of the things which has really transformed our surgery is the use of antifibrinolytics. And this used to be a little bit more controversial, but particularly the use of tranexamic acid. The problem with the epsilon aminocaproic acid is in older patients there's a risk of kidney failure with it, and I think everybody's moved, or almost everybody's moved to tranexamic acid. And so what has been shown is study after study has been shown that it reduces blood loss. And I think many places are using sort of escalating doses of tranexamic acid. Everybody thought there was going to be all sorts of horrible problems with thromboembolic events and whatnot, and that has just not been seen. So this is a study out of Columbia doing high-dose TXA, and what it's shown is that it markedly reduces blood loss, reduces complications, and the results are good. We use intraoperatively something called ROTEM, and it's a way to go and look at clot integrity intraoperatively, and it allows you particularly to know if you are having reduced fibrinogen levels. And once we put this in place, this is the results from stuff when I was at UVA that reduced our blood transfusion rates by 2/3 by having them being attentive to things like giving cryoprecipitate early in the procedure if the fibrinogen rates were low. The last thing is, again, we're talking about doing AI. This is sort of a computer algorithm thing that's put together for us to be able to predict people and how they're going to do with surgery. And as I said, when you sit down with them with an iPad and you say, look at, if we change this and you lose this weight, you do this, this is the impact on outcomes and complication rates and whatnot. It makes it so that people understand much better. So basically, again, we're doing further things, looking at it. Some of the stuff that we're looking now is looking at telomere rates and other things as a surrogate for fragility, so we know things a little bit more objectively. But the final thing is that this stuff has a real-world impact. I talked about ISSG. This is the results of the combined ISSG, ESSG data sets. And what it shows in these graphs is we are now doing our surgery where the outcomes are 50% better than 10 years ago, and our complication rates are 70% better than they were 10 years ago. And if you do all of these steps, we can do some of these people, elderly patients, who we can really go and convert their life. So what I'm saying is usually technical, it's usually fragility and comorbidity issues that are impacting our ability to do a case. This thing here, that's when you have that sick 86-year-old with severe spinal imbalance, and you're saying, should I do it? And I'm saying if we can make people so that their fragility is low, we can do these patients just do a spectacular job and get extraordinarily good results. So thank you.
3 letters, I think, summarize this lecture. It's wow, incredible. Let me bring you to one other variable. Carlos Bagley, during his Dallas time, did a paper on a variable for adult deformity surgery that I thought was really intriguing. Roughly 150-something patients published in Spine, and had the usual complication rates, 35, 40% something. The single variable that mattered most was not if patients had a complication or not, and this may go towards your outcomes discussion and perception. The single variable that mattered most for patients to decide on if they'd have the surgery over again or not, which was the key question they asked these patients after 2 years, was presence of depression and anxiety. Those who are depressed and anxious had vastly poor outcomes. Literally, all the patients who had no depression or scored low on depression and anxiety scores said yes to the surgery again, regardless of the complications. How much do mental health factors matter preoperatively?
If you looked at that graph where there are like 20 different factors, one of them is depression and anxiety, and it has a huge impact. And it has an impact, and this is one of the things where, I've got a patient right now who had a horrific deformity, and all of our preoperative testing was depressed and anxious, and sort of at the high end of all the scales. And sometimes you don't know if it's the chicken or the egg, and that's where where I struggle, and I think a lot of us struggle, is are they depressed and anxious because they've been in so much pain and they're so deformed, and if you can change them, and you see that happen, but unfortunately, I think it's about 1 in 3 that you fix them and suddenly their depression and anxiety goes. So for those patients specifically, I always send them for preoperative psychological evaluation and treatment. The fact is, though, I don't know is if having a history of it in the past, does that condemn them from all time, or if they suddenly are on some medications and are a little bit better, can we proceed? And I don't know, but I would agree with you. It is the single biggest negative as far as surgery. The other negative is somebody was showing me, somebody said, oh my God, I have to operate on this patient because their ODI is 86. I said, if they're 86, they need to see a psychiatrist. If they walk in and they're a middle-aged person with an ODI of 86, they are kooky. I said, you're just not going to ever make them better. So I don't know. And each time I get burned for trying to be, like no good deed goes unpunished, we say, well, maybe it is that they were just, it's because of that. it's not worth it. And I'm going to say, what would be, of all the stuff that the government wants to step in and do it, I'd rather have an effective AI thing where they said, you don't meet our criteria, and instead of them coming back to you begging, to say, no, you've got to change these factors to do it. So I still have made the mistake, and I've made a mistake again within this past year of operating as somebody that I am just kicking myself, knowing that this person, had a 70 or 80% chance of having a poor outcome because of their mental status and social support and everything. But your point is a good one. It's a huge problem.
Yeah. Jens, can I ask Chris a question? It's Steve.
Yeah. Oh, yes.
Can you hear me?
Go for it. Thank you. Yes, we hear you.
So, Chris,
Yes.
we get bad outcomes in patients with mental health problems because we measure our outcomes by patient-reported outcomes, right? When we get to measuring our outcomes by measured outcomes, functional outcomes, instead of patient-reported outcomes, you think that landscape will change?
Part of the problem is that some of these people that are depressed and anxious, they're the same people you have trouble. You get a report back from the aquatics therapy saying that I fired this patient because they say they're too much pain, that the water causes their skin to burn, or that they splash around for 5 minutes and are, quote, in agony. And I think that by using, if they don't reach a certain minimum of functionality, that we may use that as an exclusion criteria. But I just don't think those people are going to do well on functional testing either. I think the same things, you may have a different idea, and if you do, please let the group here know. But I just think that they are just a difficult group of patients to treat. And I think that, at least for me, I'm moving more and more, if they don't get their depression adequately treated, that they come in with, smiling with a big smiley face bounding in, that I'm having a hard time justifying operating on them. What are you doing, Steve?
Well, I think it's sort of like you're frail and very frail. I think there's people who have mental illness that's going to interfere with their function and their reaction. And I think there are people who went to their medical doctor, said, I had a bad day, got put on some antidepressant medicine, and get grouped into the same group as people with real mental illness. And I think we have trouble. We're just not good at telling those things apart.
I would agree. There was a recent publication that came out in the last 2 or 3 months that say that spine surgeons are horrible judging the mental illness of our patients, that we're horrible at doing it, and I certainly am. Sergio.
A quick question. Thank you. How do you factor in the length, the number of hours you think your case is going to take? So I think extremely long anesthesia times are also tied to cognitive impairment. Earlier today, we talked about hypotension during the surgery. So the number of hours, and if staging is an option to, split it in half, maybe that's easier to tolerate.
Yeah, so I guess maybe I'm more in the belief that I try to limit the amount of things, that my goals of correction and whatnot may be a bit less in somebody who's older and frailer than what I would do other. I just have not had, and this may be my personal shortcoming, but I have not had as good of results with stage procedures. People say that the infection rate is lower. I found that that's not the case, that I have more infections if I go back a week later and do half the operation and do that. I think that some of the medical complications, the ileus and whatnot, because you're not really getting people up and going, that I've had other problems with stage procedures. And I know that the literature doesn't show that, but I am just afraid to do limited surgery. And I also don't know the impact of, is one 8-hour operation worse than 2 5-hour operations. I don't know from an anesthetic thing, and I think again, sort of the double hit thing. You talk about, for those people that have concussions or anything else, getting 2 of anything added together quickly is worse than doing, having 1 of a little bit increased severity. So surgery, I don't know the answer to that. I try to get things done. The only exception that I make to that is I will do an ALIF, particularly a hyperlordotic ALIF in deference to Dr. Arlay. I'm a big believer. I think I've reduced my PSO surgery by 50% by using hyperlordotic ALIFs at 5-1 or 4-5 and 5-1. And I will do that in one day where it's a 2-hour operation and it's a different exposure, and you close that up and you're done, and then do a second stage posterior, stand them up and see what degree of correction to know if I can get by with a couple PCOs instead of doing a 3-column osteotomy. So I do that staged. So you've got Jens, you've got Vincent, we got Steve, we've got you. What does everybody else think? Does everybody else try to do this in a staged manner, or maybe just I'm a screw up and get all these infections and problems?
We look at Ben, just the case that was staged versus the case that were not staged, and the one-day surgery, everything is done, and they have far less complication. They do much better than just a patient being reoperated 2 or 3 days later for the second stage.
Yeah.
As opposed to what was classic, it was published 20 years ago that you had a higher rate of complication but our series don't show it. Just so when you do everything one day, you have far less complication.
And that's what Jens, you do so much. What's your thought?
We used to do double, as you know, stage surgeries in the UW days, and we found no differences in single and double, as you had participated in that also. I do think what Steve told us about the intraoperative hypotension is incredibly important. And we have more sophisticated monitoring devices now that shows intravascular hypotension in a far better parameters called systemic resistance. These are these Emerson measurement tools, and that's a far better resuscitation measure than our standard maps. So I think that avoidance of intraoperative hypotension and real-life resuscitation is critical, and limiting our surgery time to whatever, 6 or 8 hours, not going past the 2-liter threshold, if at all. Those are the big learning points for me. I loved what you said, a little bit less on the reduction, perfection, and achieving the key goals.
Well, it's funny, and Sergio knows this, having been a partner, is that we flog the patients with TXA now. And it's funny, I've got like a 1-level ACDF in the CRNAs, or the resident comes up and says, Dr. Shaffrey, do you want the 50 milligram per kilogram load or the 100 for your ACDF? I'm saying I'm not quite that bad that I need that. But for anybody with an anticipated 2-liter blood loss or greater, we're really doing that. And I think that allows us to do it more safely. I don't know, again, I don't want to do any company thing, but I do think some of the adjuncts for blood loss reduction, whatever. I don't know if there's I'm trying to think of the generic name for it, but I kind of use that Aquamanus for revision cases to paint over the stuff. And we're just starting an NIH sponsored trial looking at a supplementation of intraoperative TXA, where you put it in the wound, as they do for the hip replacement, in addition to intravenous TXA, to further reduce blood loss in some of these complex revision cases. So, I mean, there's some stuff that's coming along that will take this further. I know I've taken way too much time. I want to tell,
Chris, I have one question. I mean, we keep coming back to age, and you presented this great case of an 80-plus-year-old woman who's desperate. So it's all well and good with getting the deformity corrected and having the alignment parameters achieved. But where in your mind is the sweet spot of doing less, like, for example, just treating a decompression, or getting a foraminal stenosis treated, or doing something which you wouldn't do for a younger patient? Do you have a cutoff for that?
Well, so what I'm always trying to look to do the smallest operation. So if I have somebody that comes in and has a scoliosis in a fractional curve, and they have severe leg pain, and they say, what is bothering me is my leg. And my leg is bothering me. I've got some weakness in dorsiflexion. I'm weak. I've got pain and whatnot. I essentially, with a deformity case, am not going to do a decompression alone, but I will do a decompression and a one-level fusion, in a fractional curve. So we've looked at that, and there's something else which is in the revision stage, but we found basically 50% of those people that I do a fractional curve correction or a limited surgery, 50% of them within 5 years need a more definitive surgery. And I tell them, I tell them that. Now, some of the, for 5 years.
Yeah, but they do well for 5 years. You've gained 5 years.
Yeah, and that is a philosophy.
Yeah.
Now, what I say is I'm not one of these new endoscopic gurus. I think some of the people here are. And there are some people that are doing an inside and outside in foraminoplasty that are able to drill the bone away. And I don't have the experience to tell you whether that is a reasonable alternative. I certainly would have no problem with any one of my patients trying that instead of doing a great big operation. What's your experience?
No, exactly. That's why I asked the question, because I'm seeing the shift to either treating the symptom alone and probably kicking the can down the road, and the argument that they come back with is that, hey, I got X number of years from this, and the patient's happy, and they're not back tomorrow. But if they're back in 4 or 5 years or whatever it is, they're okay with that.
The biggest reason I am in favor of kicking the can down the road is your average 70-year-old doesn't really complain of a fusion to the pelvis. They're used to being stiff, and they don't really care. They're wearing these slip-on. You see, whatever you turn on CNN, everything is a shoe that you can step into that you don't have to tie the shoelaces. Okay, they're used to that. You do that in a 45-year-old who can't tie their shoes or put their socks on or wipe their bottom, and I'll tell you, you've got an unhappy patient, no matter how much better you made their back pain or whatnot. So to your point, the younger you are, the more I'm looking for a limited surgical intervention.
Yeah, that's great.
Well, good. Thank you, everybody.